Eating disorders are everyone's business. So it's the sport coach, it's the parent, it's the clinician, it's everyone can have those types of conversations. And obviously people go on for more specialized support, but the really early conversations ideally could be well done by everyone. And I think from my own experience, sometimes that does mean unlearning things about diet culture, about assumptions we have about people's health who are in larger bodies and things like that, that are sadly a bit firmly ingrained. I remember it took me a little while to unlearn those things.
Welcome to the Smarter Not Harder podcast, where we offer 1 cent solutions to your $64,000 questions. I'm Jodie, and I'm back with you today as we go on an insightful journey through the landscape of eating disorders with Dr. Gemma Sharp. So Dr. Gemma Sharp is a distinguished clinical psychologist and researcher with a robust focus on eating disorders and body image issues. With a PhD in clinical psychology from Monash University, Dr. Sharp has dedicated her career to understanding and treating eating disorders. She leads the Body Image Research Group at Monash University's Turner Institute for Brain and Mental Health, where she conducts pioneering research into the psychological and social factors influencing body image and eating behaviours. Dr. Sharp is also a Senior Research Fellow at the Monash Alfred Psychiatry Research Centre and has published extensively in peer-reviewed journals. Her innovative work includes developing and educating digital interventions for body image concerns and eating disorders, making her a leading voice in the field. Dr. Sharp is committed to translating research findings into practical strategies to improve mental health outcomes and has been a keynote speaker at numerous national and international conferences. So today we get talking through digital health interventions, genital body image, underrepresented groups, eating disorders and hormones, and the importance of lived experience. So I welcome Dr. Gemma Sharp. I have Dr. Gemma Sharp here. Thank you so much for coming on, Gemma.
Thank you so much for having me. It's a pleasure.
So we are here to talk about all your amazing research and your incredible field that you're an absolute whiz in.
You're very kind.
Yeah. And you have an amazing consortium coming up and in the research of eating disorders. It's a fascinating topic of mine. I've been on and discussed these sorts of topics with a few people, actually. It seems to be a beautiful theme. So I'm learning about this all the time as well and in my practice. But we are here to talk about your journey and also your research. So I want to start with, what led you here? And it's always a question of mine, just for the fascination of the person and how you actually landed in this research space.
Yeah, so I think people always think that we have this burning passion since childhood and that we go on this linear journey, but mine certainly wasn't linear. So I actually started out life as a lab bench scientist and I was doing cancer research. And it was super fascinating and I really enjoyed it. But I think what I enjoyed most was chatting with patients who were going to donate their samples to us. They're they're getting their cancers taken out and we were going to study them. And I found that I loved that people connection. And I was particularly talking with women with breast cancer a lot of the time. And they were talking to me about their body image concerns, particularly having their breasts removed and just how they felt overall as a person. And I was like, this is so fascinating, this intersection of body image and cancer. And that was actually one of my very first projects when I shifted from biomedical science to clinical psychology. And of course, the body image side really took over. It captured my attention. I was lucky enough to work with some wonderful people at Flinders University, where I did my psychology studies and then got put on a clinical placement in an eating disorders clinic, and the rest is history. I just adored it. I love the challenge of it. I loved how they were such an underdog in mental health, always unfortunately being left off of things. I was like, someone needs to champion these people and I want to do it. So that's how I got into it.
Yeah, wow. That's incredible. And it's really the people, the stories behind the people that really draws us to topics, which sounds that it's exactly the same for you. So what was the most interesting thing that you found coming from those clients or those patients that were coming in? And what sort of drew you to that?
As a junior psychologist, eating disorder presentations are generally very tricky because it's never just an eating disorder by itself. It usually comes along with a few friends, and I use that term loosely. So, anxiety, depression, OCD, personality disorders, neurodivergence. So, I think for me, it was just, wow, this person has so much going on for them at once. It was a little bit overwhelming, but I really do thank all of those people who saw me as a junior psychologist and bore with me. Goodness me, some of the silly things I accidentally said that my supervisor still reminds me about years later. But I think what I saw was they had such strength, like all this stuff going on for them, but they were so determined. And I think that was really inspirational for me. They were like, no, I really want to recover. This is ruining my life in lots of different ways. I've got all these things going on. And usually, folks with eating disorders, this is a bit of a generalization, but often they're quite high achieving people with very lofty goals. And you go, hey, I just want to help them reach these goals and be the amazing person that they want to be. So, those experiences were really foundational and fundamental for my career.
Yeah, wow, that's incredible. From that journey now, obviously, into the research field that you're doing,
Yep.
what obviously explain a little bit more scope around what the field and what you're researching in. Obviously, there's a lot that I want to sort of dive into, so that consequence of that. But obviously, your body image research group and everything that's going on there, maybe give a bit of context around all of this.
Yeah, so I've always liked combining research with clinical work because I feel like what I see in the clinic gives me questions that I want answered from a research perspective and vice versa. I think people will say that my research team is probably the most overstretched at Monash University because we have 7 different themes broadly across body image and eating disorders. And I suppose we're known as the group that will take anything on, which is exciting, but also daunting. But I think probably we're quite well known for our digital health stream, which is mobile apps, bots, online interventions. We're also very proud to champion underrepresented groups. So people in larger bodies with eating disorders, intersection of eating disorders with health issues like menopause, for example. So we really love to look at those kind of understudied topics, as well as big consortium like projects. And in terms of our body image work, we have a specific focus on genital body image, which I started in my PhD and absolutely love because we want people to feel confident about their whole bodies, not just the parts that are easy to talk about. And then we have all of our aesthetic surgery work where we do a lot of work with surgeons and aesthetic practitioners to upskill them on assessing mental health in patients. So that's a bit of a whirlwind tour and it's all lots of fun. And I am very honored to do the work that I get to do.
Yeah, that's incredible. So maybe outlining the genital is incredible. I didn't even realize that this was the forefront of the research at the moment. It's incredible. But
Thank
for
you.
each aims and goals that you're looking at, obviously you're finding that information, and then obviously you're doing it for an end goal of support and how that can help people, and obviously patients, clients, and also practitioners in the spaces. So we're maybe diving into the different sort of realms, the streams that you've got there, and giving a little bit more information about each of those areas.
Sure. So I think what we like to do is very translational research, that it's going to benefit people as soon as we can. So sometimes that's quicker than others, but hey, it's all a journey. So I suppose with our digital health streams, I was lucky enough to lead the world's first eating disorder prevention chatbot called KIT. Now it's called GEM. But basically, I suppose harnessing the power of artificial intelligence to shoulder some of the load of helplines, therapists, services, because we know there aren't enough eating disorder clinicians to go around, sadly, and that's not going to be solved anytime soon. So we And obviously it's been quite interesting. Our journey with AI started in 2018, so 6 years ago, and we've seen huge changes in that time, and just the way we've been able to improve our interventions as well, but also keeping them safe and ethical has been challenging, but very rewarding. So I think probably people maybe know us best for that kind of work. In terms of the underrepresented groups, so people in larger bodies, we've been doing a lot of work with people in primary care about how they discuss weight with their patients in a non-stigmatizing, holistic way, so that people are most receptive to that kind of support if they're seeking it. I suppose the intersection of eating disorders and obesity has become a more recent passion of mine. How do we help people best attending to their mental health needs, not just weight focused, because that can really sometimes cloud clinicians' judgment. So that's been a really cool area, and obviously very translational, being working with practitioners at the coalface, and our menopause and eating disorders work. So I think we know that eating disorders there are certain risk periods in people's lives. So puberty, pregnancy, and menopause, if we're speaking specifically about people with ovaries there. And menopause seemed to always keep getting left out of the conversation. And I had quite a few patients come through who are experiencing perimenopause and an eating disorder. And I was like, oh, okay, I'll give them some information. And then I was like, oh, there's nothing. Oh dear, we better make this. So that's been something more in the last year and a half that I've absolutely adored. It's been some of the funnest research I've done, just looking at how we treat eating disorders at midlife and how we've really neglected that group, and our understanding of the hormonal intersection and eating disorders is still very much lacking. So we found this when we were making our resource, which is hosted by Eating Disorders Victoria. Big shout out to them. So we gave people as much information as we had, but really there wasn't all that much really. And I think what we also found was people who have eating disorders often have irregular or completely absent periods, menstrual periods. So how would they know if they're going through menopause? So the women were just saying, I have no idea. Understandable. And their doctors are also going, we have no idea. So we're like, okay, let's at least try and give the information that we have, and obviously do more work in that space. I feel like I'm waffling on. I do apologize. Feel free to chop this out.
I'm going to just cut in there before you move on to
go for it.
Areas, just because this is also a fascinating part of my practice, in that very much uneducated areas of perimenopause, and a lot more people only in the last, I feel, year or so have been reaching into giving more information to the public, because we're undercared for in those areas. And women, like I have come just before I spoke to you, I had a lovely lady going through this stage and just feeling like they are monsters because their body is so different. So pardon the interruption, but I have some exciting news for all you health and wellness enthusiasts. And we have a new cohort coming on the 9th of September 2024 for Home Hope Metabolomics. So Home Hope goes beyond traditional medicine, focusing on detecting and correcting imbalances for optimal health. Our metabolomics module delves into the intricate metabolic processes of the human holobiont, combining advanced metabolic testing with a holistic approach to wellness. So ready to optimize your health? Visit homehope.org, products, metabolomics to learn more, and use promo code podcast10 for a 10% discount on the metabolomics module or any other certification from Home Hope. And don't forget, we have a new cohort coming on September 9th. Their mind is so different. They're feeling like they're depressed and anxious, and there's so many different components of that. Not only they have that midlife area of what am I doing with myself now, I'm aged, and then as you say, the aesthetics then comes into it, where they're like, now I am getting older and how do I deal with this? And it's a very midlife type crisis where no one talks about. Really, really tricky. So I love that there's more information coming and being looked at and being put to the forefront, at least anyway, and just being recognised.
Yeah, at least health practitioners asking the question and not just assuming everything is eating disorder related. I think that was really coming through in our research. Oh, you're feeling down because of the eating disorder. Or if you just ate, you'd feel better. And it's no, I'm going through menopause. I'm pretty sure the periods have always been wacky in my life, but something is different here. And I think it's about absolutely empowering women to trust their bodies, and if they're not happy with that answer from that particular practitioner, then to go to the next one. And we have included in our resource practitioners who are recommended by the Australasian Menopause Society, AMS. So there are people out there who this is a particular specialty or interest for them.
Yeah, hormone shifts change so many parts of the body, and I love
Absolutely.
being brought to,
Yeah, exactly. That estrogen drop, just as you were saying, the feeling depressed, feeling anxious, these are absolutely real. These are not, they're not some kind of wacky perception. Like the impact of estrogen on the brain, it's so protective. You see this in younger women with a cycle every month. So imagine complete estrogen deprivation. Of course, you're going to not be feeling good about yourself and your life.
continual PMT. It's not good.
Indeed. Indeed.
Yeah. So, Gemma, do you find that, and just on that note, when I travel to America, and obviously this podcast is predominantly American-based audience, but when I travel there, there's a lot more information, there's a lot more education around hormones and hormone balancing. And I do love to talk about hormone optimization as well as health optimization, but it is something that is a lot more forgiving, I feel, in other countries compared to Australia. Do you feel that we're behind in that at all, or is it just not even an observation you've considered?
It's a very, this question is an excellent one. I love this cross-cultural comparison of hormonal impacts and understanding. I think the health system in the States is very different from ours. And I know your listeners will know this anyway. So I'm sorry, listeners, if you're bored by this, but I just wonder, because the States has such like privatized healthcare, and you see all these ads for like medications on TV and things like that. I feel like healthcare and medicine are very much in their consciousness, potentially a bit more than in Australia. And I think even through the ads, you can learn about different medications. I suppose I'm basing this on a fairly recent trip to the States, and I was just astonished at the level of healthcare advertising. And so I think that's good. It's raising people's awareness to what support is out there. But I like the Australian healthcare system too. I just think it's potentially a symptom of a broader attitude to health difference between Australia and the States.
Yeah, that's good points. Good points. Yeah, interesting to think about across, as you say, and seeing what the differences are. So
Yeah, maybe in England, very different again, like having just a completely sort of public service in HS. Like gosh, it'd be interesting to do that study.
yeah, overarching, I see clients in all countries, and I feel like there is a general lack of information across all boards
Yeah.
of where we should be at in terms of taking control or taking power of our own bodies and having the knowledge to do that. And I think there is a general lack in overall. So that
Oh, 100%. And we do our best with the research we have, but it just shows how much more we need to do. Like our guidelines are based on the limited research we have.
Absolutely. So shifting into sort of like your next area out of
Sure.
hormone, sorry for interrupting you there.
No, not at all. Thank you so much for the questions. I suppose I will say that as much as we like to do translational research, I never forget my lab bench roots. So let's not forget that eating disorders are caused by a complex interplay of genetics, psychological, social, and environmental factors. And we do have some great, I suppose, genomics initiatives going on around the world, which is fabulous. But we're never going to find that sort of one gene that that causes eating disorders. If it was that easy, we would have done it already. But I think what we are finding is that eating disorders look quite a bit like some other mental health conditions. And we know the most about anorexia, and it has a lot in common with, in fact, schizophrenia and OCD. And I'm really fascinated by, with schizophrenia having those delusional aspects, is eating disorders a manifestation of delusions about the body? I would love to delve more into that. And I think I don't spend a lot of time at the lab bench these days, which saddens me, but I get to do it through collaborations. And I think we all need to be working together, those working on the kind of the social prevention aspects, those working on the psychological interventions, which I spend most of my time on, and the genetics folks, so that we can make those personalized medicine recommendations for eating disorders, because at the moment it's a one size fits all, which doesn't really fit many people. So that's another area that I'm particularly passionate about.
Yeah. And it's no magic wand, like you say. There's nothing that can be waved and fixed, but there's so many complexities around this. I've chatted with Susan Rolson, who's leading up the research in terms of eating disorders, which is interesting, just she went into that field. But as we were talking with her about the body dysmorphia, and it's very interesting, like you say, it aligns the same realm of schizophrenia and OCD and this obsession about how, but the perception is completely different. And it's
exactly, yeah, and BDD and eating disorders often come together, so it's no surprise.
Yeah, absolutely. There's also that component of, like you say, that's the specific medicine support, the specific medicinal, but also nutritional support, and correct education around the wording, because the perceived, as you say, I think the education around practitioners, I really love that you say that you're teaching practitioners how to talk to clients and patients, because it can be one or two words that will trigger or turn or create chaos in that client's or patient's life.
Absolutely. And the client or patient just never comes back. So you never learn what you did potentially wrong. You just know that they left. And I think I was very lucky in my early training, because with the patient's consent, we taped the sessions, and I was scrutinized for every single word that I said. And I'm not saying that I'm perfect now. In fact, I probably was better then. But yeah, I think language is so important when discussing weight, body image, and eating, a lot more than some other areas. So it shows that just acting with sensitivity and care can go a long way.
Yeah, absolutely. Being understood, just general human traits, isn't it? That
Exactly.
humility. Yeah. So, Gemma, what about the genitalia area? That's fascinating.
Yeah.
Talk to me more about that.
Sure. I promise not to take up the whole time, though, because I do love this area, and it stems back to my PhD. And the reason I started looking at it was just that labiaplasty, so the surgical reduction of the inner vaginal lips, was going gangbusters in the 2010s. Like, just we were seeing the numbers go up exponentially, and everyone was going, why is this so different from other forms of aesthetic surgery? And I found that it was a lot of the same kind of body image drivers as for other aesthetic procedures and also eating disorders. So it was the way women's genitals were displayed in pornography and on other online sources. It was the way their intimate partners were talking to them about their genitalia, the way they were discussing their genitalia and pubic hair removal practices with their friends. It was a complex interplay there. And I just thought, goodness me, we don't even really have genital body image interventions here. We're not discussing genitals in the body image context at all. So it's no wonder that people are going through life across the gender spectrum. I should say we've done work with transgender and also cisgender men in this area too. Super fascinating. But I'm like, okay, no one's really touching on this. And so I've apologized in advance for all the potential puns that are coming through my speech here.
We love it. The more fun, the better.
So thank you, appreciate it. So I was just like, okay, so we know some of the driving factors. Where's the education here? And so been lucky enough to be working on more educational pieces going through high schools in Victoria, promoting positive genital body image. And it's just interesting how different the understanding is for vulva owners versus penis owners, which we've been doing quite recently. Generally speaking, girls and women, they don't really know their anatomical names. They're not even sure how many holes, quote unquote, are down there. They don't know the functions. And we're like, okay, back to basics here, folks. Let's get this right. Let's not call everything the vagina, because it's not all the vagina. The vagina is just the inner part. Whereas when we did this with penis owners, they were like, we know the functions, we know the names. We don't, what we want to know is, does size impact relationships? Like, it was a completely different conversation. And with them, it was more about self-acceptance around penis size, that penis size functionality. You can have a relationship with any size penis. It was more around that kind of side. So we were watching our kind of side-by-side intervention videos recently, and I just went, these are so different. So yeah, with the vulva owners, it was exploring diversity, making sure everyone knew the different names, challenging if there was an appearance ideal. Whereas the penis owners, it was quite an interesting conversation. They were convinced that size did matter. They weren't going to be convinced otherwise, no matter how much research we threw at them. So it was about, no, you need to just accept your penis for what it is. Yeah, it's just fascinating, the differences there. And of course, that ties into a gender discussion, doesn't it? You know, generally speaking, vulva owners don't go, because I'm a vulva owner, this is my gender. But penis owners are like, no, this is my gender. This is me because I have this penis. So just radically different perspectives.
Very fascinating. So in terms of jumping into outcomes, treatments, what you're looking at trying to support clients and patients with, and obviously practitioners and clinicians, how are you finding, even for any field that you want to talk about there, but the failure fascinates me because, again, like you say, it's not spoken about as often as it should be. So what are you then looking for in terms of future directions and support? And yes, I know you have the apps, like you say, and doing the consortium information sessions around that. So what does that look like in terms of the scope of outcomes?
It's a huge question, and thank you for that. And I'll do my best to formulate a coherent answer here. So forgive me if I go off on a tangent. Hopefully not. There's a small scale and then there's bigger scale, isn't there? So with the consortium, the goal is to bring together all the pockets of expertise in eating disorders we have around the world and make sure all voices are represented. So lived experience, researcher, clinician, industry, not-for-profit, policy, because often we're not working together. And I think this has unfortunately slowed breakthroughs and treatments and cures for eating disorders, as sad as that is. So I think it's about sharing knowledge, sharing data. I think we will know a lot more about genomics if we share all of our samples, for example. So it's not about creating something extra. It's about harnessing the resources we have to come up with good answers. Because I think everyone's, build another centre, put more beds in a hospital. Of course, that's helpful, but we do actually have heaps of expertise and resources already in this space, and that's about coming together to push for new treatments that have that lived experience voice at its heart. I think eating disorders has progressed quite a bit in terms of making sure lived experience input and co-design is in every research project, and we've certainly been doing that for a number of years, but it's not done in every area. So this consortium would hopefully make sure that all voices were there at the table at the start of an initiative, not just at the end going, what do you think of it? And then they might go, actually, this is complete trash, and you've spent all this time and money on something that'll never be used. And unfortunately, we see quite a bit of that in digital health, that people make apps and no one uses it or likes it. So trying to avoid things like that.
Yeah, and it's fantastic to be able to have that input earlier on from, like you say, multiple expertise minds with multiple experiences in the industries that you are wanting input into, so you can make a better outcome program, anything.
Exactly. Yeah, even designing the experiments at the lab bench. It's, who cares if you're using this particular model of cells if it doesn't replicate a human disease at all? Like, it's a waste of time. Yeah, we want it, that bench to bedside co-design process.
And which it's free. I've signed up, and they can So pardon the interruption, but I have some exciting news for you who needs to enhance their focus and productivity. This podcast is also brought to you by Transcriptions, the makers of precision-dosed, physician-formulated pharmaceutical-grade formulas in the form of a buccal troche. So blue-carnitine is a favourite of mine for focus, and it combines CBD with other nootropics to help you achieve calm, focused, long productivity. Whether you're tackling a big project or just need a mental boost or a podcast, Blue Canteen has you covered. So visit troscriptions.com to find out more about their innovative products. And for our podcast listeners, mention the code POD10 to receive a 10% discount on your order. Now, buckle up and back to the show. It's since September 25th.
Yes. That's correct. Yeah, September 25th. You can join online. And yes, we're committed to keeping the consortium free because we want everyone to be able to join. I think there's enough kind of paid eating disorder research societies around the world, and they're doing great jobs. But I think there is this space for us to really be that collection and allow people to connect. Like just speaking with people already, a particular app company said to me, we have all this data but no researchers to help us analyze it. And my gosh, what an absolute gold mine there. So their goal for the consortium is to connect with researchers and do amazing improvements to their apps. And all of the lived experience people who've signed up, they're just like, we just want our voices heard and to influence research and policy, and absolutely laudable goals. So everyone will have their own reason for joining, and we'll do our best to try and deliver on that.
Yeah, no, that's incredible. So I just wanted to dive into a little bit more. I'm fascinated with it as well. But so what you're finding in the research, like key pearls that you found already that will help support people through this, talking to the people who have the eating disorders, even what they should be looking for, or family members, because I see a lot of this where clients will come in and they know a family member is suffering with this or are not able to or not knowing support and what direction to put in. A lot of the mainstream, like you say, ways of supporting these, I don't know if you would say conditions or issues with people and how they feel about themselves, is not effective. I hear that, and there's not much to be done in terms of where people should be going for these sorts of issues. But I think would be useful.
I think it's really interesting, isn't it, when it's someone who's worried about someone else, the person themselves coming for support, because obviously the person coming for support for themselves has been on quite a journey to even get to you. So they've had to overcome probably a lot of shame and stigma and self-doubt. So I suppose I always really congratulate anyone who reaches out for help, because it's such a huge first step, and it shows how important those early treatment experiences are. Because say if someone's been on this long journey, they've finally got the courage to come see someone, and then their first session is not very satisfying for them, that would just be so disappointing, and maybe they never come back for help. Like that, I suppose, just thinking of treatment trajectories with a particular project we're working on at the moment. So I think early getting really good early support. And I think, as we were mentioning a little bit earlier, like it doesn't necessarily have to be hardcore treatment straight away. It's just about speaking with sensitivity, empathy, and validating people's concerns. Like any practitioner can do that. You don't need to be an eating disorders expert. I suppose we had this tagline in it was, I think, 2023, our national eating disorder strategy, that eating disorders are everyone's business. So it's the sport coach, it's the parent, it's the clinician, it's everyone can have those types of conversations. And obviously people go on for more specialized support, but the really early conversations ideally could be well done by everyone. And I think from my own experience, sometimes that does mean unlearning things about diet culture, about assumptions we have about people's health who are in larger bodies, and things like that that are sadly a bit firmly ingrained. I remember it took me a little while to unlearn those things.
Yeah, absolutely. I guess for tips and tricks for practitioners, what are the outcomes of some of even the medications or medicines that are available?
So there's only, according to my most recent studies, only one medication approved for eating disorders in Australia, and that's an amphetamine called Vyvanse for binge eating disorder. So it's not something where we went out going, let's find a medication for binge eating disorder. It was just that it was found that people who were experiencing ADHD had reduced their binge eating episodes, and that's, this might work for binge eating disorder. So I think I wish there was more research coming through in pharmacotherapy for eating disorders, because I think there's so much work to be done there. So really, yeah, it's only Vyvanse. That's it. So people will probably be prescribed antidepressants, antipsychotics, probably for their other conditions like anxiety, depression, OCD. They might be taking those sorts of things. And often when people come to me, they might be taking four or five medications. And I'm like, wow, I suppose that's a bit of a thing, polypharmacy, that if that medication doesn't work, let's add another one. No, don't add another one. Maybe think about the previous ones. So there's definitely more medication work to be done. It is an emerging area. There are research studies going on. I think my clients all know that I have a big research life, but I'm always very keen to encourage them to join research trials to help us build the evidence for these other medications like psychedelics, for example. And let's not ignore the elephant in the room of the GLP-1 receptor agonists of Ozempic, Mounjaro. So we're obviously seeing that they're very effective for diabetes and promoting weight loss. I don't think I've seen any trials for impacts on eating disorders, but I'm certainly open to seeing those trials done, because I think because they're already coming through all of our clinics. There wouldn't be a practitioner out there who doesn't have patients who are already taking these medications. So why not see the impacts on eating disorders? If they do not have good impacts on eating disorders, then absolutely we know that, we avoid them. But if they can benefit, then let's get the information.
Yeah, absolutely. And I think it's a multimodality approach, and that's what I've observed from talking and looking and obviously hearing you speak now, is that it feels like it can't just be that, as with everything, it can't just be that magic pill or magic fix. That
Yes.
really a multimodality approach that's well
Yeah.
organized. Hence the consortium really getting that combined knowledge and combined input
Exactly.
to give that
Yeah.
about.
Exactly. So we have, for example, one of the people on our founding panel is someone who works on GLP-1 receptor agonists. And so we definitely wanted the lab science and drug discovery components in there, because we know that therapy alone is failing quite a lot of people, sadly. So we need to, as you were saying, take a multi-pronged approach for a complex disorder.
Yeah, absolutely. And a lot of the things in terms of my practice and how I can input in any way, but it's more of that underlying foundational, even nutritional cofactors, even with neuro.
Absolutely.
So there's a lot of even nutritional biochemistry and even metabolite type testing with that metabolic
Absolutely.
support.
Yeah.
There's so much to.
Absolutely. I think we're so lucky. Like, one of our consortium sponsors is Microba, and they do a lot of work on gut microbiome and oral microbiome. So I think, as you said, nutritional psychiatry, there is so much there to untap, maybe a little bit quicker than some of the drug design pathways. We know how long those clinical trials take to get to approvals. Why not investigate nutritional psychiatry, the influence of our dietary choices on our mental health? Because there's a lot there.
Yeah. So Gemma, with the different types of eating disorders, I just wanted to touch on this because I don't think we've actually contextualized that yet. So are we looking at different types of treatments for different types of eating disorders?
And I suppose yes and no is the answer to that. Typical psychologist, not giving a direct answer.
Yeah.
So I think, say with, for example, anorexia nervosa, there is someone needs to weight restore for that, as opposed to someone who is in a normal or another weight class. There's a different approach. But in terms of the work I do as a psychologist and some of our interventions, we do tend to take more of a transdiagnostic approach. So obviously people are experiencing different behaviors. So some people might be binging and purging, some people are just binging, restriction. But at the core is a desire to control weight and shape. That's at the core of a lot of eating disorders. Not all, though. I want to mention, say, ARFID, for example, avoidant restrictive food intake disorder, does not have body image concerns at its core. So that's a different type of treatment again. But say anorexia nervosa, bulimia nervosa, binge eating disorder, to some extent, that weight and wanting to control it is the core psychopathology, and just the manifestations of it, the behaviors are just coming out differently.
Yeah, so fascinating. So fascinating. And like you say, and even with the genitalia, it's sort of like that overarching shame and wanting to control an aspect of self that hasn't yet been met or is dysmorphic in some sort.
Absolutely. And isn't it like there's so much in life that we can't control? Why wouldn't we try and control what we can? It makes complete sense. But yes, our weight and shape are not entirely within our control. In fact, we're finding out so much more about how we end up being certain weights and sizes. Like I think genetics and environment play such a huge role in these things.
Huge component, and something that we definitely don't have control over and quick enough to do so either, which is also. So with and I guess this is a little bit a forward, but and it's hard to say, but do you see trends in where a lot of these types of eating disorders start? So is it a lot of trauma-based triggers? Is it a lot of yeah? So is there any sort of commonalities around that you've noticed in your research?
Yeah, and I think that's definitely holy grail as well. Like, what are the antecedents? How do we get in there as soon as we can? And I wish we had more research to draw upon, but certainly trauma can play a role in how we view ourselves and our bodies. And in a chaotic, traumatic environment, we try and reclaim control where we can. And sometimes that can manifest as an eating disorder. I suppose something else we do see is often anxiety precedes the eating disorder. So a young person who's experiencing anxiety, like a real little person, might go on to develop an eating disorder as a teenager. So it's showing a bit more of an anxious, perfectionistic temperament. And sometimes that can be an antecedent. Obviously, there's those genetic factors that we're still working out. It might not even be at the gene level. It might be at an epigenetic level, which is basically another word for saying what switches the genes on and off. It might be that level rather than the actual genes. So there are many things that can be in there. And I suppose being in a very weight focused, a very appearance focused environment, it might be a young person who's engaged in a sport like gymnastics or dance or something like that from a young age. They might be a little bit more prone to developing an eating disorder, just giving that narrative they're receiving a lot of the time.
Yeah, absolutely. It has a huge influence of the world that they're involved in early on. And I've noticed
exactly. Yeah, and that's the stories we tell ourselves about ourselves and our bodies are developed early in life, and the adults around us and our siblings and our peers can absolutely play a role in how we talk internally about our bodies.
And the social environment has changed
hasn't it just?
speed of light in the last sort of 10 years. And it makes me feel old, considering that I remember not having a smart.
You are not old. I just want to validate that.
It makes like the technology and like you say, AI as well. AI has increased dramatically in the speed of which it's being used and utilized in spaces. But then the social aspect, the Twitter and the Instagrams and the of the social acceptance, like you say, even pornography with genitalia. There's so much more known and seen out there.
Yeah, absolutely. Compared to we used to just hang out with the people in our villages, and they would be the people we would marry and have children with. So our worlds have expanded astronomically.
Absolutely, which has obviously outstanding and resounding effects on a way that we view ourselves and comparison. So I think that's
exactly
to have and contend with and also educate around, but it is quite hard with constant input.
Exactly. Were we ever meant to be this stimulated in our environments? But maybe we were meant to be bored some of the time, but not a chance with everything we can access now.
Absolutely. So Gemma, with my sort of coming to a close, I don't want to take too much of your time, but we always ask of the 3 things that you would recommend in your field, in your space, in your research that you can live or be smarter, not harder. And it's just because of the podcast name. Like just some 3 tidbits, and even you can direct it towards clients or patients or practitioners. So in any direction, or even just how you like to live your life smarter.
Absolutely. Thank you for this. And I must admit, I went like quite broad when you asked the question. Yeah, this is everyone who listens to this is going to laugh at this because I say this It's like a Kenny Rogers song. Know when to hold 'em, know when to fold 'em. Like knowing when something isn't serving you well anymore, I think is a hard thing, but once you've realized it, it's so empowering and it can be quite frightening. And I suppose that's my second point, that like behavioral change starts with small maintainable steps. It's not I'm going to run a marathon tomorrow. I'm sure some people could do that, good on them. I'm not, but yes, small sustainable changes are the ones that are maintained. So I always encourage people, first one, know when to hold them, know when to fold them, know when something isn't serving you well. Second step is break down your goals into small achievable steps that you can maintain. And number 3, I think is I think from an evolutionary perspective, we know that we have to listen to other people's opinions of us, because in the past it probably kept us safe, kept us fed. If you were socially outcast, you probably died by yourself. So I totally get that. But I suppose I'm always someone like, look at the quality of the information you're receiving and your amount of attention you give it. So I think, unfortunately, sometimes people do say nasty stuff to us, right? And it's not necessarily good intentions. And I'm always like, what's their motivation? And do I really attend to that? And flip side, someone might give us really nice comments and it comes from a place of like genuine love and support. And it's okay, I'm going to attend to that. So I suppose I'm someone who, I'd hate to see someone's self-worth be impacted by complete nonsense commentary. I know it's easier said than done, but just, yeah, look at the quality of the evidence you're receiving and what you actually should be attending to.
That's beautiful. And I love that you've placed it in an evolutionary perspective, because it is, our bodies have been
Yes,
surviving in so many instances.
exactly. Yeah, so that's why the social comparison is so ingrained. That's an old part of the brain. Where am I in terms of the pecking order in my clan? But I think once it starts damaging self-worth and our internal narrative, then it's time to really question that external input.
Yeah, absolutely. And so fit in for eating disorders as well.
Yes.
Yeah, absolutely. Wonderful. All right. So Gemma, let's mention where to find you, to find your work.
Yes,
And
sure.
obviously the consortium. We'll be including this in the notes as
Thank
well.
you.
Everyone can head on to the link and join and input all of their beautiful information as well as they wish, and then see your information on the website too. But if you want to list it off here, that would be brilliant.
Yeah. Oh, so the actual web address, or?
Well, yeah, so the web, obviously you've got the university as well.
Yeah, absolutely. So you'll find me on Twitter/X at Gemma Sharp 11. If anyone's still on there, good on you. Seems to be leaving in droves. I'm also on LinkedIn under Monash University. If you Google my name, Gemma Sharp, and Monash University, you'll find links to everything I've ever done in my life, probably. And then our consortium website.
So it's the Consortium for Research in Eating Disorders. So Core ED, isn't it?
It is. So it's core-ed.com.au.
Okay, amazing. So I've written it down here as well. So International Initiative uniting researchers, clinicians, individuals who live with lived experience and advocates to advance eating disorders research. Just incredible. I love this. It's just amazing.
Thank you so much.
I will see you there, but thank you so much for your time today. And I really appreciate your knowledge and your work. So thank you so much.
Thank you so much for the opportunity and the brilliant questions. I've had a great time.
Yeah, incredible. Thanks so much, Gemma. And until next time.
Thank you.
Thank you so much for listening and joining us on the Smarter Not Harder podcast. We hope you found today's podcast and information inspiring and insightful. And be sure to subscribe for more expert insights and practical advice on health and wellness. And remember to check out the Consortium for Research in Eating Disorders at Core ED website, and for more information on their groundbreaking work and the consortium coming up in September. So until next time, stay healthy and stay inspired.